احنا we have to start the next session. والحقيقه انا بشكر استاذتي الاستاذه الدكتوره ايناس شلتوت على تنظيم السيشن ده، وهي طبعا استاذتنا استاذ الدكتوره ايناس شلتوت رئيس الجمعيه المصريه لدراسه السكر والميتابوليزم، واحنا فخورين انها معانا ومديانا الشرف الكبير انها بتشير في المؤتمر بجلسه. Let me call the chairperson دكتور عمر، دكتور عزيز مدكور، دكتور عزة فراج، دكتور سامح مخلوق.
I think we are late. We will start this very important session about the ominous dial. Combination of hypertension and the diabetes, and I think the number of diabetic patients who are having hypertension is not less than 70 to 80% of those, which make us know how much this problem is very eminent. We'll start by Professor Dr. Eines Shaltout. It will give a broad scope about the problem from the start, the diabetic hypertensive patient. Dr.
Thank you very much, Mr. Chairman, Ustazi. Thank you very much for the Hypertension Society برئاسة أستاذ دكتور محسن إبراهيم على الدعوة الكريمة أن جمعيتنا تشارك حضراتكم النهاردة في المؤتمر المهم. I'm going to talk about diabetic hypertensive patients. And let me start with this number that we are having 537 million adults living with diabetes, so diabetes is spiraling out of control. And according to the International Diabetes Federation 10th Atlas, in December 2021, in Middle East and North Africa, we are having 73 million person living with diabetes. 44% of diabetic patients worldwide are not diagnosed, and we are having 10.5% of the global population having diabetes. And by 2045, we're going to have 783 million persons living with diabetes. 4 in 5 people having diabetes are living in middle or low income countries. So diabetes hits the poorest hardest. And during 2021, we had 6.7 million deaths due to diabetes. And let me start with some updates on the types of diabetes according to ADA 2022. We are having type 1 diabetes, which happens due to autoimmune beta cell destruction, leading to absolute insulin deficiency, and include latent autoimmune diabetes of the adulthood, and type 2 diabetes due to progressive loss of beta cell function and beta cell secretion on a background of insulin resistance. And the third type of diabetes is specific types of diabetes, for example, monogenic diabetes, for example, neonatal diabetes, and maturity onset diabetes of the young, and disease of the exocrine pancreas, for example, cystic fibrosis and pancreatitis, drug-induced diabetes or chemical-induced diabetes, such as glucocorticoid use or the treatment of HIV or after organ transplantation. And the fourth type of diabetes is gestational diabetes, which happens to the first time during the second or third trimester in a non-diabetic patient or non-diabetic female prior to gestation. And when I talk about type 1 diabetes, which is called insulin-dependent diabetes previously, or juvenile onset diabetes, about 5 to 10% of the total diabetic persons are having type 1 diabetes. And there is autoimmune markers, including anti-GAD antibodies, anti-insulin antibodies, or anti-islet cell antibodies. And type 1 diabetes is defined by the presence of one or more of autoimmune markers, and it has strong HLA association. It has multiple genetic predisposition and unknown environmental factors, and although those patients are not typically obese, the presence of obesity does not exclude the presence of type 1 diabetes. And the other autoimmune disorders which may happen in type 1 diabetics are Hashimoto thyroiditis, Graves' disease, Addison's disease, celiac disease, vitiligo, autoimmune hepatitis, myasthenia gravis, or pernicious anemia. Gestational diabetes, it happens in 3 to 10% of pregnancies. It is due to placental hormones that cause insulin resistance, and these hormones are cortisol, progesterone, human placental lactogen, prolactin, and estradiol. These are the risk factors for gestational diabetes: impaired glucose tolerance, the presence of impaired glucose tolerance or impaired fasting glycemia, family history of type 2 diabetes, overweight, increased maternal age above the age of 35, and certain ethnic backgrounds. Cystic fibrosis is the most common comorbidity in people with cystic fibrosis. Is cystic fibrosis related diabetes. It is associated with severe nutritional deficiency, severe inflammatory lung disease, and greater mortality. These are the monogenic diabetes causes, and it causes beta cell dysfunction and natal diabetes, or MODY. It occurs in 0.5% of all diabetics, and the MODY, it is characterized by onset of hyperglycemia after the age before the age of 25, or sometimes it's after the age of 25, and it is characterized by impaired insulin secretion with minimal or no defect in insulin action. We have many types of MODY. Some of them are very mild disease, which does not necessitate treatment except with the presence of gestational diabetes, and other types of MODY, which is treated by sulfonylureas. Now I come to how to reduce diabetes complication, and this is the standards of medical care, the AGA 2022, by glycemic management, blood pressure management, lipid management, or agents with cardiovascular and kidney benefits. Patients with type 2 diabetes have multiple risk factors, and among them is hypertension, which happens in 75 to 80% of type 2 diabetic patients. And hypertension is a strong risk factor for atherogenic cardiovascular disease, heart failure, and microvascular complications. According to the UKPGS, the United Kingdom and Prospective Diabetes Study, tight blood pressure control led to clinically important reduction in the risk of fatal or non-fatal endpoints related to diabetes. And according to the UKPGS, there was modifiable risk factors for coronary heart disease present in type 2 diabetes, and these factors are increased LDL cholesterol, decreased HDL cholesterol, raised blood pressure, hyperglycemia, and smoking. And careful management of those 5 risk factors contribute to less complications in type 2 diabetic patients with myocardial infarction, and also renin, angiotensin, aldosterone system inhibitors, beta blocker, statin, oral antiplatelet therapy, and early revascularization was associated with lower 1-year mortality in coronary patients with type 2 diabetic patients. There is importance of management of all these risk factors, and this was shown in 2 important trials, STENO2 trials, in patients with type 2 diabetes and microalbuminuria, and in the Swedish Diabetes Registry, when targeting these 5 important risk factors led to little or no excess risk of deaths, myocardial infarction, and stroke compared with the general population. then it's important to target these risk factors, especially hypertension and hyperglycemia. These are the treatment goals according to the AGA 2022. The blood pressure targets should be individualized. For patients with diabetes, hypertension, and having higher cardiovascular risk, with existing atherosclerotic cardiovascular disease or 10-year atherosclerotic cardiovascular disease more than 15%, the blood pressure target is less than 130/80. In low risk of atherosclerotic cardiovascular disease and less than 15% risk, to treat the blood pressure to a target of less than 140/90. And in pregnant ladies with diabetes and pre-existing hypertension, the target is systolic between 110 to 135/85 milligram mercury and millimeters mercury, and this will lead to reduction of the risk of accelerated maternal hypertension and minimizing impaired fetal growth. For treatment strategy, we start with lifestyle intervention, and lifestyle intervention consists of weight loss when indicated, a dietary approach to stop hypertension, which is DASH diet, and to increase the physical activity. For pharmacological agent, when the office-based blood pressure is equal to or more than 140/80 millimeter mercury, we should initiate one medication and to titrate this medication to reach the target. When the office-based blood pressure is equal to or more than 160/100 millimeter mercury, we should start with 2 drugs or a single pill combination of 2 drugs. ACE inhibitors or angiotensin receptor blockers are recommended first-line therapy for hypertension in patients with cardiovascular disease or renal disease. An ACE inhibitor or ARBs at the maximum tolerated dose should be the first-line therapy in patients having urinary albumin to creatinine ratio more than 300 or equal than 300 milligram. And for patients treated with ACE inhibitors or ARBs or diuretic, we should follow the serum creatinine and GFR and serum potassium at least annually to be monitored. And let me end with AGA 2022, the initial blood pressure, if the initial blood pressure more than 140/90 and less than 160/100, then we start with one agent. And if there is albuminuria, we start with ACE or ARBs. With albuminuria or even cardiovascular disease, we start with ACE or ARBs. If they are not present, we start with ACE, ARBs, calcium channel blocker, or diuretic. We should use lifestyle modification for all patients. And if the initial blood pressure is 160/100 or more, we start with 2 agents. If there is albuminuria or coronary artery disease, we start with ACE or ARBs and calcium channel blocker or diuretic. If there is no albuminuria or coronary artery disease, we start with 2 of 3 options, ACE or ARBs, calcium channel blocker, or diuretic. To assess the blood pressure control and to assess side effects, if treatment is tolerated and target is achieved, we continue the therapy. If the patient is not meeting the target, we add another agent, a complementary drug class according to the initial drug used, ACE or ARBs, calcium channel blocker, or diuretic. If we are having adverse effects, to change to another group of the 3 groups, and to assess the blood pressure control and adverse effects. If not meeting the target or adverse effects using these medications, then we may consider adding mineralocorticoid receptor antagonist, or to refer to a specialist with more experience in hypertension management. Let me end with this slide, and thank you very much.
Thank you very much, Dr. Ines. I think we need a program for prevention of diabetes. في حد عنده سؤال للدكتورة إيناس قبل ما تمشي؟
Dr. Ines, you did not mention the sodium glucose co-transporter inhibitor in the management of diabetic with hypertension. Does it have a role or just in heart failure?
The effect on hypertension is modest, around 3 to 4 millimeter mercury. So it's not considered an hypertensive medication, or antihypertensive medication. The effect is modest. يعني 3 أو 4 مليمتر يعني ده مش كفاية، لكن مع استخدامه مع بقية الانتي هايبرتنسيف ميديكيشن ساعات بيحصل الضغط يوطى، ففي الحالة دي بنظبط الدواء التاني، أو لو كنا بندي دايوريتك ممكن نقلل الدوز اوف دايوريتك.
Thank you very much.
اعتقد ان هو الاضافه دي اديتيف ثيرابي، مش فهو بيضاف لما يبقى فيش كنترول، وهو بينفع في الاثنين، بيحسن الدايابيتس، حسن الهايبرتنشن، بيعمل بروتكشن بالنسبه للهارت فيلير. فاعتقد ان هو 10 مللي جرام كاديتيف ثيرابي بينيفيشال.
وفي كلام دلوقتي على ان في الريزيستنت هايبرتنشن بنستعمل SGLT2 inhibitors for management of resistant hypertension.
طب بس الايفكت في الاخر هيبقى ايه؟ مش عارفه يعني. هي نفسها الترايلز بتاعتهم بتقول 4 مللي جرام ريدكشن ان بلاد بريشر.
up till now اللي بيعملوا SGLT في الجسم مش
معروف. مش معروف، بس هي الاستاديز بتاعت حتى الشركات يعني بتقول 4 مليمتر mercury، لكن طبعا added benefit مفيش مشكله.
Thank you, Dr. Ines. Thank you يا جماعه.